Hey everyone, we're back to talk about how to immobilize fractures. So basically, we're going to begin with these simple steps. First thing you want to do is immobilize the injury. And ideally, that'll be with the help of an assistant, somebody else in your crew. It doesn't need anybody that's specially trained, just somebody to hold the injury, make sure that it's stable as you're gathering all your materials. In a wilderness scenario, this could take a few minutes as you're trying to find the right sticks or find the right camping equipment to create a makeshift splint. In a situation where it's just you and the victim, it could be asking the victim to immobilize the injury. But again, our number one goal is to avoid further harm. Then you're going to assess PMS, which is pulse, motor function, and sensory function. So you're going to check those before you splint. And the reason for that is you want to see if you're making it any worse or any better, right? So if you check pulse, motor function, and sensation, and you just basically evaluate, let's say, the arm, what's the color look like, is it clammy, et cetera, and then you put on the splint and go back and evaluate it again, and the motor function is diminished, or there was sensation and now there's not sensation, there's something wrong with your splint. So you want to check before and after. You can consider gentle traction, but we're not trying to reduce the injury. So your goal is not to reset the injury in its proper way. There are professionals that can do that way better than you or I could. So we're going to get to the hospital and allow that to happen. However, sometimes it's useful to provide traction. We'll talk about those scenarios. So basic steps: manual immobilization, check PMS, consider traction, splint, immobilize, and then reassess PMS. Right? That's what we're going to do. And don't get freaked out by the drama. What I mean is these are going to be really gory, possibly. They're going to be probably really kind of weird, crazy, disturbing kinds of injuries. You've got to be the professional. If you see something like this, your first thought has to be, A, there's significant bleeding there. I got to control the bleeding. Don't freak out about the bone. What do? The rule is still the same. I've got to control the bleeding. I can't apply direct pressure to a wound like that, so I got to get a tourniquet on. And the next thought is, this is a real high probability of infection. Broken bones, exposed, creates a high probability of infection. So I want to get that covered with some kind of sterile dressing as soon as possible. They don't have to be dramatic. However, you still need to recognize the possibility of an infection. This is also an open fracture. So underneath that relatively small injury is a broken bone that is basically exposed itself or broken through the skin. So in that case as well, you want to be cognizant of that. You don't want to try to reset or reduce that, but you want to be aware of the high possibility of infection and deal with it appropriately. So sometimes it's gory, sometimes it's not, but your steps are always the same. Okay. When do we want to think about reducing or applying gentle traction? Gentle traction. There's never a scenario where you're going to put like 50 pounds of force on any kind of body part to realign it. Whatever you've seen in the movies, we're not doing that. You're not doing that. Don't ever do that. However, when do you want to apply some gentle traction to try to reduce something? Well, there's a few opportunities or possibilities. One is where perfusion seems to be compromised. So basically, the broken bone is blocking blood flow, and that's creating a problem. You may then consider gentle supportive traction. So if you've got an arm and it's got an injury here, you definitely want to provide support. You definitely want to provide gentle traction, not just pulling in one spot, but pulling with a wide grip so that you're not applying pressure in one particular area. When you've got severe pain, that's another possibility, because it could be that a broken part of that bone is pushing into some muscle tissue and creating some pain, and you may be able to alleviate some of that pain. When you've got gross angulation and you simply cannot move the person or immobilize the injury without resetting it to some degree. So I actually at one point stopped at a car accident, or whatever called a car accident, and somebody's femur, it was just sort of like completely sticking out of their leg, and there was no way we were removing them from that car without straightening that up to some degree. And I'll talk about femurs and how that's an issue. But there may be times when you need to kind of just readjust things just in order to be able to provide first aid or CPR or whatever. In all circumstances, gentle motion. Okay, here's a special case. Sherry's going to help me out with this. What is the bone right here called? None of you know. Sherry knows.
Femur.
Surrounding the femur here is a really large set of muscles. And so this is a special case where traction is actually indicated or called for in an emergent situation. The reason is you've got bone here, and if that bone breaks in the middle, so what we call a mid-shaft break, not a break here, not a break here. This would be a hip injury, actually. This would more likely manifest as a knee injury. But right here in the middle, you've got bone that, well, I guess bone like this, that then breaks, and the muscles are so large, they can contract in and pull the two bone fragments together, which will tweak out and cause some really significant damage. So, in the special case of a mid-femur fracture, with no other major associated injuries, and certainly no injury in any other part surrounding the femur, providing traction can alleviate a great deal of pain and avoid further injury. In an EMT setting, we use a traction device like you see there in the slide. You aren't going to be hiking around with a traction device. So we will, when we get together, talk about how to do that. But there's nothing dangerous there. Can you just lay down and give me your leg? If there's indication that I've got, say, angulation here or any kind of injury here, mid-femur fracture, I may want to then support the leg and provide a gentle amount of traction pulling down. Not a huge amount of traction, 15 pounds of traction or so, pulling down gently on the leg. If I could then ask the person, okay, I'm going to pull on your leg a little bit here and see how that helps your pain, all right? So expect me to pull just a little bit. Here I go. How's that feeling?
Feels okay.
Okay, good. Is that making things feel a little better?
Yeah, it feels a little better.
Okay, cool. We're going to hold on to it like that. Now, that's manual, right? So one person is holding that there. Somebody else in your scenario is going to have to find a couple of sticks, and we'll work on how to do that, that can extend beyond the leg. And actually then we can wrap up, and I'll show you how to do this too, wrap up a strap on the boot and pull that leg out, holding that manual traction mechanically so that we can evacuate the person out. That is the one scenario where applying some traction is a reasonable first step in an emergency situation. Does that mean you absolutely have to? No. If you're uncomfortable, you shouldn't do it. If there's no available sticks around, you shouldn't do it. If I'm pulling on it and the patient starts screaming in pain, I'm not going to do it. But in a scenario where it has alleviated or reduced the pain for the patient and makes it easier to hike them out, you can do that. Here's a little tip, and again, we'll talk about this in person as well. But as you are looking for the sticks to do this, this leg is now shorter. These bones have broken, they slip past each other, and her massive leg muscles have pulled all the bone together. So now this leg's like maybe 2 or 3 inches shorter. If I find sticks that fit this leg, they won't allow me to apply appropriate traction. And I'm going to be putting sticks up against a leg that really hurts. So what we're going to learn to do in person is find the sticks and measure them on the leg that's not broken, to make sure they extend appropriately beyond the leg that's not broken. And then the maximum traction we promote, and we're probably not going to produce that much traction, but the maximum traction we promote would be to elongate that leg back to the normal length of the other leg. But it's likely we won't actually even pull it that much. And if it takes more than just a little bit of force to do that, we're not going to be applying that force. Thank you. I appreciate the use of your leg. And you can see that x-ray there shows you kind of how that femur can kind of be pulled in like that. Reducing that also reduces the possibility of having significant blood loss for an injury like that. Having said that, again, make sure it's a femur fracture, because if it is a pelvic fracture, if it's a hip fracture, etc., you can provide some pretty significant damage rather than assistance by providing traction. So you want to make sure that it is just a femur fracture alone. Okay, now we get into splint material. So this is where Sherry's really going to help me out. There's different materials we can use that we're going to use in person. One is a SAM splint, which comes from the military, and it looks like this. And it basically is a piece of metal with a piece of foam on either side. And in the military, when they describe things, they describe them in reverse order. So basically, the last adjective is the most specific. So this is a metal aluminum splint, SAM, splint, aluminum, metal, is what it is. Now, here's the thing. When this is just flat, as it was a second ago, it's not very stable. That's not going to splint up anything. But if you curve it, it creates a really stable potential splint. So, yeah, check it out.
How's it do?
I know. So this is actually great because these roll up pretty small and they can be shaped into, and they're fascinating for people. They can be shaped into just an ideal splint for a particular scenario. So let's try one of those first. And they come, by the way, in different sizes. So here's a bigger version of them. They're a little beat up because I've used these in first aid training more than a few times. Let's imagine that Sherry has an injury here. Okay, she's got a break there, and it's possibly two bones that are broken, because as you remember, there are two bones right there. And if there's enough force applied that's big enough to break one, it's big enough to break the other. Sherry is rightfully offering me the arm so I can splint it, but I am a first aid professional, so I know that's not the way I'm going to do it. I'm going to say, okay, to my friend, hold that there, somebody will hold it there, and I'm taking this arm. Now, the reason I'm taking this arm is I need to fit this to her arm, and I don't want to do that on the arm. That's super painful. I'm going to adjust this a little bit ahead of time by making that curve, and then I'm going to get it so it fits her. Now, if it extends a little bit beyond her elbow, that's perfectly fine, but I'm really interested here. What I want to do is I want to bend this in this case a little bit like that, so it provides a little support and keeps her arm in a functional position. I don't want to splint her arm so that this is stretched out like that in an uncomfortable way or tweaked in like this. So this allows me to provide a little support. And part of the reason for that is because what I want to do, and this is really important, when I immobilize any injury, if it is a break in a long bone, I want to splint it from joint to joint. So my long bone is broken right here. I want to isolate, or I should say immobilize this joint and this joint. On the other hand, if I have an injury in a joint, I want to immobilize from long bone to long bone. So if her elbow were injured, I would want to get this here and make sure that I got it strapped in right there. And in this case, get rid of this little wrist tweak, strapped in right there so it holds her elbow in place. Having said that, if it is painful for her to extend her arm that way and it's much more comfortable like this, then I splint it like this. So typically we would splint an elbow at a right angle, and this can handle that. And I could put straps here and straps there. I'll show you how to do that to isolate it. Having said that, there are times when I don't want to do this, in particular if it's painful for the patient or if there's swelling, because this could cut off circulation. So then I might want to extend the arm a little bit to make sure I'm going to get adequate perfusion to the fingertips in the process. So in this case, there's a little bit of a gentle bend. Once I've gotten that bend measured, there I go. And now it's this arm that's injured. I come over to this side. And now I say, okay, I'm going to extend your arm a little bit. How does that feel? Is that okay?
Mm-hmm.
All right, awesome. I'm going to have my, in this case, her hold it, but I would have an assistant hold it. And I'm going to take just regular gauze. Now, I could do this with different kinds of bandages. I could do it with straps. I could do it with all kinds of things, but I'm just going to use regular gauze. I'm going to shape it a little bit more around right
Can
there.
they see?
Yeah, that's a good question. Here we go.
Should we move up a little bit?
No,
If our stupid dog wasn't laying there.
I think that's okay, right? Yeah, okay. So I'm going to wrap this up. I try not to waste too much material, so I've used this gauze, I think, twice before in instructions, so this will be the third time. When I wrap gauze, by the way, there's a little cue here. Notice that the gauze is coming out of the roll closest to the patient, if I were unwrapping it like this, it'd be a pain in the ass. This is a little nugget of information here. Make sure that when you're unrolling gauze, you're unrolling it so that the roll is basically able to roll on the patient. It makes it so much easier. There we go. So much easier to wrap up. So basically I roll all the way over to hold the piece in place, the SAM splint in place. In the end, I have some options. I'll show you how to do this, but there we go. I'm going to just take some nice 1-inch medical tape. If I can find the end, there it is. And there we go. Now, would that be okay? If I were driving her half an hour to the hospital or 50 minutes to the hospital, that might be okay. If I'm hiking her out, I'm going to take another gauze. I'm going to start on this end, and I'm going to start rolling back that way. Once I'm done, what am I going to do? I'm going to check for PMS again. So now I'm going to say, okay, can you feel me touching that finger?
Mhm.
Which finger am I touching?
Do you want me to give you the finger?
Isn't she so helpful? Yeah, a middle finger. All right. Can you squeeze my hand for me? Right, and that's pretty firm, nice little grip, and if it were a weak grip, that'd be disconcerting. And then I'm just generally looking at the fingers. I could even, I don't recommend this, but it's a possibility out there, I can check what they call capillary refill. So basically, I can squeeze her fingers briefly. As you know, if you squeeze your fingernail, it turns white. It should flush back up to red in less than 2 seconds. In her case, it really is virtually immediately. So I know that I've got good perfusion there. I don't necessarily recommend it, but it's another way of just basically checking perfusion. What I recommend is just check the temperature, check the skin condition. It's not white. Temperature is good, a little cool. And she's got good sensory, good motor function, good sensory function. So I'm pleased with this. Am I done? No, I'm not done, because I need to now immobilize this. So what I'm going to do then is I'm going to probably, in this case, bring it down to her body, and maybe, right here, I'm going to do something I shouldn't do, but it'll just allow me to give, there we go. If I immobilize it like that, instead,
I don't think they can see.
put it across her body. Here, I'll get on this side. Stepping over my dog.
Don't let us bother you, bud. And just to be clear, he initially said this was a break down here, but he actually immobilized the joint.
Oh, yeah, I switched, yeah.
He switched, so not to be unclear there.
Right. Yeah, so basically I'm now mobilizing a different area, and there's different ways of doing it. What I'm gonna do here is I'm just gonna make a little sling for this. And what I've done is I've taken, I should show this here, a triangle bandage. So these are typical medical supplies, and they are basically a bandage cut in a triangle shape. There you go. I call them triangle bandages because I'm old, and that's what we used to call them. Now they're typically called cravats, which is the French word for tie or scarf. I don't know why things changed, but they did. I'm going to tie a little bit of a knot at the end of this triangle bandage, and then I'm going to use it to create a splint. And the way I'm going to do that is, here's the key, very carefully, because her arm hurts. Oh,
You're just gonna move over so that you can see a little bit.
okay, cool. So I'm going to carefully move that under her arm. Ideally, somebody supporting it, and then I'm going to tie it up on either side of her. Now, if I'm clever, what I'm going to do is tie this up here to the side. And the reason for that is if I put, and I'm instead going to put the knot right here in the back. But if I put the knot right in the back, she's got a knot right in the back of her neck, which is not super duper comfortable. And this is maybe going to be here for a little while. I'll finish it up in a second. So what I would do if I did that is take a little gauze pad, maybe just a 4 by 4 inch pad or something, and put it back there and then wrap it in place. Just to keep a little padding behind her neck so that it's a little more comfortable. You don't want to make it uncomfortable. Once I've done that, I'm going to take another one. I'm going to sway this in place by putting that across, just like that, and tying it here. There you go. And now she'd be ready to hike out. And I'm pretty comfortable that that's not going to create any further injury for her. A little tighter?
Yeah.
Yeah.
I think, yeah, I'm a little, it's wrapped a little tight because we changed the position, so my fingers are going to sleep.
Okay. So that's good to know, because when I'm all done, what do? I check her PMS again, And if she's telling me, oh, her fingers are going to sleep, then I want to evaluate the bandage to make sure they're not cutting off circulation, right? Just as a quick note, what I suggest you do with these is use what's called a surgeon's knot. Do you have any idea what a surgeon's knot is?
Oh, gee.
Basically, I'm going to use an overhand knot, but instead of just overhanding it once, I'm going to overhand it twice. And then when I secure it, I will twist back the other direction for a single overhand. So double overhand and then back for a single overhand. So a little bit more complex than your typical square knot. The reason for that is this. As I put this in place and she loses function in her hands, if I use a square knot once over and then another time over, I'm sorry, a surgeon's knot, I can tighten it up and it kind of holds in place. So now I can adjust a little more easily. If she says that's too loose, there, now it's a little tighter. If she says it's too tight, I can loosen it a little and it'll hold in place. Once I know that it's right, then I just lock it in with that single overhand. So it allows me to adjust things a little bit more precisely. That is one way to do it, but honestly, just because I wanted to demonstrate the SAM splint, I like the SAM splint for long bones. I don't like the SAM splint for joints as much. So if I were doing this joint, I would not do it with the SAM splint. And the reason is that SAM splint is great when it's curved because it's stable. But that elbow wouldn't provide that much stability. I'd be pretty comfortable with this because it provides some stability and because I put a strap there. But ideally, if her elbow were injured, I'd actually probably do a figure 4. So I'm going to use instead a splinting board like this. It's foam padded on one side and a board of cardboard, actually, and sometimes it's wood on the other side. You're going to be working with these two. Can I use this one so that?
Yeah.
Okay.
So the SAM you like for long bones, and we're doing an elbow.
Yeah, the reason is that's really good to highlight this. This way, when curved like this, a SAM is really stiff. But on an elbow, I've got to open it up to allow a little bit of bend in the elbow, and then it's slightly less stiff. So it's not a bad tool, but if I'm really trying to mobilize an elbow, if I've got, let's say, a dislocated elbow where even a small amount of motion really hurts, this is going to allow a small amount of motion. So in order to show you how to use a SAM splint, I use it on an elbow. I would be really thrilled with this SAM splint on a forearm injury, a wrist injury, something like that. But I do want to, if it's a wrist injury, I want to mobilize a hand, I want to mobilize it to the forearm. So I need to get something that crosses both of those. In the case of the elbow, this doesn't work ideal. So you've got to work out the material that you got to work with what you got, but you got to work out something that's going to be ideal for the scenario. Okay, let me see if I can save this triangle bandage, this cravat. Okay, I'm going to do something a little different here. I'm going to try to immobilize, in this case, this elbow, because I think it'll be easier to see. And I'm going to use a figure 4. And what I'm going to do is I'm going to take this cravat, not this one because it's all unwrapped and messy. I'll take this cravat and I'm going to put it over. And then I'm going to take this cravat, which is still folded up and nice, and put it over like that. Okay, now I'm going to put this, ideally somebody's holding her arm, in this case Sherry's holding her arm, just like that. And I'm going to take this cravat and twist it around a couple of times and then bring it back over like this and tie it in the beginning of a surgeon's knot. Why the surgeon's knot? Because now I can tighten it up and it will hold in place. And then I'm going to take this other cravat, if I can find it. Did I just cross them over? Yeah, hold on.
Something weird happened.
No, I swear, I know what I mean.
All 3 pieces are over there.
I think I caught one with the other. Okay, so don't do that.
Okay, got it.
Notice though, if there was a lesson there, it's A, everybody makes mistakes, but B also, I'm not stressed about it. This is a broken arm. It's not cardiac arrest. I have time. Okay, there we go. Now I got this. Okay, cool. Wrap it a couple of times. Bring it a little bit over. And excuse me. Tighten it up with half a surgeon's knot. Okay. Now what I've done is I've improved my immobilization of the joint. And then I would ask her, how does that feel? And she would probably tell me this one's too loose because it's way loose.
So essentially, it doesn't cover the elbow, it like makes like a.
Yeah, exactly. And the goal here is to stop the elbow or help the elbow stop from bending.
Yeah.
I'm not completely done with it yet, but I think Sherry would agree, it'd be really hard for her to extend her arm.
Yeah, it is, it doesn't look like much, but it does.
Right, and then, once it's done and it's where I need it, I lock them in place, just a single overhand on either side. I can make it a little tighter than that, but I'm honestly trying not to make this tight because I'd like to reuse this for the next demo, right? And once I'm done with that, what do? I do exactly what I did before. I put on the sling. I put the swedge around it to hold it in place. And it's now isolated and protected.
Yeah, do that again.
Oh, sure.
And you're gonna show them how to do this tying.
Oh, I'm gonna show them and then you're all gonna have to do it a few times. So the reason that I like these videos for this class is because it means that when we get together in person, I can spend a lot more time watching you do stuff rather than having to do it myself.
Oh yeah, that's pretty.
Right?
Oh yeah.
Yeah. And now, is it weird that it's an angle like that instead of, a perfect right angle? Whatever's comfortable for the person. The goal here isn't for you to fix anything. It's for you to isolate, immobilize, so that we can get her to care without further injury.
Yeah.
Yeah. And I'd wrap one around the other way as well.
It actually feels better than touching the elbow.
Yeah. Yeah, that's part of the advantage of it,
Yeah.
for sure.
Yeah.
No, that's it. Sorry, you're stuck. So basically, one note I want to make is I'm leaving these kind of loose. So if this looks a little sloppy loose, it's because I don't want to sacrifice all my cravats for the sake of one demo, because I want to show you other things. But you're going to make it a little bit tighter than that and secure those knots a little more tightly, right? But that's how you would use a padded board like this. Having said that, you can also use a padded board for the legs. So, if you don't mind, would you lay down?
Sure. It's not a good angle.
Okay, so, this is actually perfect. You're laying in exactly the right position.
You might have to come behind so that your
Yeah,
back is
I
not
think so.
blocking your view.
Okay, so normally when somebody has a leg injury, what you think of is, oh, I've got to immobilize that leg injury completely straight. No, you don't. In fact, in a lot of leg injuries, it's going to be much more comfortable at a bend. And in this case, the patient's already at a bend. It is reasonably comfortable. Why would I want to change that? I didn't actually ask Sherry to take this position. I didn't expect her to take this position. I thought I was going to do it with a straight leg, but I'm digging this actually. Okay, here's what I'm going to do. I'm going to take one of these boards and I'm just gonna stick a cravat around it. I haven't done one of these in a while. This is fun. It's exactly this way. These are, by the way, the cheapest bandages or triangle bandages you can get. So they're kind of rough. They're kind of not great. You probably want to spend a little more money. I think I got like 20 of these on Amazon for $5. So spend a little more money than that. And I'm going to actually put this one on the outside of her leg and this one on the inside of her leg. They have padding on one side. The padding goes toward the leg, right? Does that make sense? And then I'm going to pull through. Oh, thank you. My cravat and tighten it on this other side. That will hold it in place. Am I done? No, of course not. But now I can secure this in place. So I can take an additional cravat and I can secure this upper portion through something like that. I'm not even a surgeon, it's not there, so demo. In person, we'll kind of do this and I'll show you how to make it super secure, etc. But on the video, I don't see any advantage in doing that. I'm going to fold this up a little bit. And then I'm going to wrap this one around here. So I double wrap it, and knot will end up on this side here. Oh, no, it won't, right there, that's fine. I want the knot not against the patient. In this case, it's not. Not. And there I go. Now I've got a leg that's more immobilized, more secure. Yeah, right. Yeah. And so if I'm moving this patient around on a stretcher or whatnot, that's going to help support it. Am I done? Well, no, it's an injury. I might have wanted to wrap it in gauze ahead of time. I want more wrapping, but I want to provide that preliminary care. I know I left it loose because I'm trying to keep the triangles. So basically, I would do it a little bit tighter than this. It's a little bit sloppy, but again, that's because I'm trying to be able to reuse all my triangle bandages very quickly. The other option we have, there we go. If her leg, we'll use the other leg, if her leg was straight, is I could use a couple of bandages like this right alongside the leg and immobilize the leg in a straight position. That'd be a little bit easier to move her out for sure, but if that's not a comfortable position, I'm not going to force her into that position, right?
I might suggest you put your bandages all three on before you even.
Actually, that's a really good point. That's the next step.
Ah.
So let's imagine, you can scooch up a little bit if you want. Right at the end there. There you go. Let's imagine we have a more typical scenario, which is she's laying down, this leg is really injured and really hurts. What I want to do is use the natural gaps available to me around her leg to get bandages in place. So in this case, what I want to do is put the triangle bandages on first, and I can slide that under her knee and then scooch it up higher. I don't want to push it in under here because now I have to move the leg. Why would I want to do that? Take the next one, slide it under her knee, and bring it on down lower. Take another one. I could have done it under the ankle as well. There's some space under there, but the knee is better for our video, so I'm going to put it in the video. And I'm going to move that right there. I've got the triangle bandages in place. I would probably also put another one right here, by the way, but this is for the sake of demonstration, so you get a sense of what we're doing. I put, whoops, the longer one on the outside of the leg, the shorter one on the inside of the leg, and then with some assistance, I'm going to secure these. And in this case, I'd like to secure these against, in fact, let me just do this so you can see it, against the back of the wood so that I'm not having a tight knot, excuse me, right up against her leg. There we go. And what I would normally do, by the way, is ideally, I've got those in place, they're not that tight. Put them all in place relatively loose, and then adjust the tension and position for comfort. So right now it's not that tight. Once I'm sure it looks okay, now I can tighten up from the outside, move it in, and provide some stability. And ideally, again, I don't have another triangle bandage handy, or I would show you, but I got the foam facing the legs. I put another triangle bandage here. And again, this may not be the end of it. If she has a knee injury, I probably would wrap the knee in gauze ahead of time to protect that knee from bumps and pressure during the process, right? So there's different ways we can use these boards, and we're going to be using them in different ways. However, when you're hiking, you're unlikely to be carrying a whole set of splint boards. So what we really need to do is be able to do this with something that is not designed to be used for this purpose. And we can do that with 6. So if she had an injury to her leg here, I would want to be able to splint from joint to joint, right? If I don't have boards, then I would have to find 6. And frankly, I didn't spend a lot of time preparing, so I just got these from the backyard. Sticks that would allow me to create some kind of splint. Is this going to be an ideal scenario? No. Ideally, I want something better than this, but these 2 bones have worked pretty well. In fact, this one kind of curves to her. No, because it doesn't. There we go. What I'm doing is fitting this to her body a little bit, and I can provide reasonable immobilization with something I find just around the campsite. In this case, is that okay?
Yeah, you might wanna add some clothes.
Yeah. Is it rubbing? Yeah. So I didn't mean to make that tight. So how would I do this? Yes. First thing I'd probably do, in fact, let me just do that. What I'm doing is trying to keep this video short, so I'm skipping steps, and I hope you understand the steps that I'm skipping. We won't skip them in person, so you'll get a sense of the training. But typically, I would take gauze like this. Let's say that we have an injury here, and the injury is right there, so it's okay if she bends her knee a little bit. I'm going to provide gauze support. Notice again the way I'm wrapping, not super tight. I would have checked PMS ahead of time. I'm going to check PMS after because I want to make sure that I'm not accidentally providing any limits to circulation. There we go. There are a few different ways you can secure bandages. So I showed you one, which is tape. There's a couple others. One is take your scissors, cut it down a little bit, tie it in a knot. Oops. And then wrap around either side and tie it on the other side. And that'll work out well. Another way, oops, that worked out pretty so well, I have trouble taking it off. Another way would be to save yourself some of the gauze, go around, and tie it off like that. So you've got different ways that you can do it, and of course, if you got tape available, the tape will work well too. So in this case, I had it wrapped nicely, so I'm going to try to recover that, bring it back here, bring it back there. And the goal of this is not to stop bleeding. There is no bleeding. The goal of this is simply to provide comfort and support, maybe a little compression depending on the nature of the injury. This one's going to cut off. Okay, there we go. I put in 3 triangle bandages. And these 6 are not ideal, but they're okay. I'm going to lay your foot down. There we go. And I'm going to wrap these up with the triangle bandages. If I could get underneath, did I poke you with something?
That stick is poking.
This one?
Yeah.
Oh yeah, Jesus. So ideally in this scenario, what I'd probably do is take these sticks and take a knife to them and smooth them out a little bit because there are rough spots here. As I said, I didn't prepare a super long time for this video, so we would do that to secure and isolate the leg. And then we might actually even use a little gauze to secure the place as well. And these sticks, yeah, what got her here is that. And yeah, I would not use that as a regular splinting device, to be clear. So
put a t-shirt over it.
Well, I'd probably just take a knife to it and whittle that off in just a couple of seconds, but yeah. Okay. It's just too much work to undo this gauze. So. There we go. Okay, so there's some possibilities for the kind of splinting we're doing in person. In person, we'll go through that in a lot more detail and go through that step by step, but I just want to give you some sense of what to expect there. The other possibility for a splint, by the way, is twofold. First, I want to show you these, so we get to play with these. This is a cardboard splint. It comes in plastic. Whoops, open that up. And it's basically just a bit of cardboard. And again, cardboard, not super secure, but if you bend it, it gets pretty secure. And it's got foam on the inside. So if we needed to isolate an arm, that would provide a fair amount of comfortable support, right? And again, you don't need to get fancy with this. Pull out the gauze and just do 2 rolls of gauze wrapped around it. And then we can do other crazy things, like, for example, use existing camping gear. This is an inflatable thermarest bed rest. Can you lay down again? If I had some assistance, here, put this leg down so they can see a little bit. I might just wrap this leg in a firmer rest. Take maybe there we go. Take maybe some tape like this. This is going to be the most comfy, I think, of all. This is not great tape. It's painter's tape. And I'll be honest with you, I'm using painter's tape because I don't want a bunch of duct tape all over my thermarest. But in the real world, we would probably use duct tape, and I always keep a small roll of duct tape in my backpack. Or if you didn't have duct tape, you could use straps. These are the straps that hold the thermarest of my backpack, and I could easily put those straps around it. Use that open part of the knee so I don't have to move her leg any more than I need to. And get that strap. In this case, the strap's a little on the tight side, but I think it's going to be okay.
Oh no, this is clearly the way to go.
This is it. Are you just going to be wearing this all day now?
This is way more comfortable than any sticks.
So the nice thing is, yeah, exactly. Wrapping this up with some tape, and then the final step. Is inflating. So now, yeah, it's going to pull on the tape. So now, yeah, comfy. Yeah, right. Except it turns out painter's tape is not the tape to use, but we knew that. So you could do this with a camp pillow, you could do this with a thermarest, you could do this with anything else. And this actually simulates what's there listed as an air splint. You could think of this as a form of an air splint, but basically there's air splints and vacuum splints. You may be carrying an air splint. In fact, air splints are pretty cheap, pretty easy to access. So putting one in your camping kit would not be a terrible idea. But basically it's the same thing. You slide it on, it's uninflated, you inflate it, and it creates a nice little splint because it's sort of stiff. A nice little advantage of air splints is they also provide pressure. So if you've got an area with a fracture that's also bleeding, this will provide pressure to stop the bleeding, as well as to immobilize the fracture. Vacuum splints are super cool, and you're not going to have one of those, but EMS uses those. They even have full body ones. So basically what it is like a kind of like a beanbag, and you kind of put that around a body part where you could use as an entire stretcher and lay the patient down in it. You suck out the air and it gets stiff, right? Because there's no air to allow the movement of the beanbag or whatever. And so you got the nice, it was a real flexy thing that shaped around the patient. And once you suck out the air, it becomes stiff and, excuse me, locked in that position. So it's super cool. I might be able to bring one in to show you what they look like when we meet in person. But to be honest, you're not going to be carrying one of those in your backpack. So we'll do a little more practice with makeshift splints out of camping gear. Basically, my preference is camping gear first, and then stuff you find in the wild if the camping gear is inadequate. Jackets and pillows also make a great splint. The splint doesn't necessarily need to be dramatically stiff. So if you've got a shoulder injury or an elbow injury or a hand and wrist injury or even a foot injury, wrapping it up in a pillow and wrapping that in some duct tape and keeping that secure is perfectly fine. Okay, a few guidelines to think about. Splint long bone to long bone or joint to joint. If you have a long bone injury, it's joint to joint. If you have a joint injury, it's long bone to long bone. Remove those rings immediately, and any other jewelry as well. And while you're at it, check out the jewelry. What I mean is, there's medical jewelry. So if you don't know the person, as you're checking out their arms, legs, etc., look for medical jewelry. You might find a necklace or a bracelet that says something like they're diabetic or have some other kind of existing injury that you want to be concerned about. Heart condition, etc. There are even some that are DNRs, are do not resuscitate orders. So if you're doing CPR, what I advise initially is don't delay the CPR for the sake of looking for medical jewelry. But if you do run across a bracelet that says do not resuscitate, that could change your approach to CPR, obviously. Okay, or at least you should notify, if you're calling the medical folks, you should notify them that you found that bracelet and ask for advice. If you have a pulse oximeter, which is a little finger thingy that I will show you in person, it's hard to show on video, but it's just a little finger device that will show you how much oxygen saturation is in the blood. It's good to put that on the extremity after a splint just to monitor whether you're getting decent perfusion. You want to avoid causing pain. One of your goals is to alleviate pain so you can move the person out. So if you can get, once you've got the person splinted, remember, ask that question, okay, how's the pain now on that same scale of 1 to 10? She answered, I think 10 before. So, because she's a crybaby. So if now it's a 5 or a 6, that maybe things are looking good. Don't forget the padding. Also, don't forget the padding. And don't forget the padding. You're doing this for the comfort of the patient. I didn't do a really good job of padding when I was using the natural wood there, but I just want to kind of show you that natural wood can be used. But we want to take our time. If it takes you half an hour to get a splint on, that's perfectly fine if it's a comfortable splint, right? Way better than 5 minutes for a splint that is causing the patient pain.
Nobody will forget the padding after that.
Exactly. Yeah, I think we're going to splint everybody's extremities with old boards with nails in them, and so that you'll all remember padding. You might also consider cold packs. It can certainly help alleviate the pain. So you got in your first aid kit probably some chemical packs that will get cold upon crushing. It's not a bad idea to just even stick those in. So once you got that, sling all set up, put a couple of cold packs in there. Just to provide a little bit of cooling. Okay, so we talked about tibia, fibula breaks. Basically, if one breaks, it's likely that they're both going to break. We've talked about knee splints as well. Realize that in person, we're going to be going through how to do those leg splints because those are pretty common injuries. Another very common injury is wrist injuries and elbow injuries. So we're going to be talking about those as well. Again, sling at 90 degrees is perfectly fine. Sling down to 120 degrees or anywhere in between that is comfortable and providing adequate perfusion for the patient is fine as well. If you have a dislocation, things change. To be clear, EMS never reduces dislocations. So if you call an ambulance and you've dislocated your shoulder, and you tell the EMT that arrives, hey, can you help me relocate my shoulder and put it back in place? They will say, absolutely not, we're bringing you to the hospital. They're not allowed to do that by law. And the reason is that there can be complications and other problems. However, in a wilderness scenario, you may need to do that because if you're 3 days out and you've got somebody with a dislocated shoulder, the best resolution may be to get that shoulder back in position before you hike them out. And the principle, well, there's 2 key reasons for that. One is you don't want them to be in excruciating pain with a non-functional arm for 3 days as you hike out. And the second reason is because inflammation is going to set in relatively quickly. So in the first few minutes after dislocation, you have an unusual opportunity to put it back in place with relative ease. A day later, after there's a lot of inflammation, potential tissue damage, it's going to be much harder to get that back in place. So to be clear, if you're out for a day hike, even an overnight hike, and you can get the person to medical care within a few hours, you want to immobilize and get them medical care. If you're out on a 1 or 2 month excursion and it will be several days before they get medical care and they're in pain, you may want to consider reducing that shoulder dislocation back into position. And here's a really cool way to do it called the Stimson method. Sherry, can you lay face down from with your arm hanging over?
Maybe.
See how this works.
Okay.
See if I can. Yeah. So here, adjust our camera slightly, is Sherry laying down with her arm. Basically, her shoulder is dislocated here, and there's muscle tissue around it that's getting inflamed and going to make it hard to come back into place. What we can do is apply gentle traction in this direction because most dislocations tend to have the arm muscle slipped back. And so if we push gently the arm muscle forward, it will actually allow that arm bone to slip back into position. You could do that just with gentle traction on your own, but this could take an hour or more. So what we basically do is we take some kind of strap. You could use something like your triangle bandage, wrap it around a few times, tie it up, tie it again on the other side, and then tie that to a modest amount of force, like 10 pounds-ish of force. And what I've seen happen here actually, it's just that people don't have buckets. The really clever way to do this is to tie this to a bucket and then gently add water to the bucket until the arm starts to settle back into place. If you are hiking with something that can contain water, like you've got a couple of water bottles where you can add water to them, 3 water bottles or maybe a larger water container, that could work dandy as well. Gently add force, pulling the arm forward, and what will happen is that arm will kind of gently slip its way back into position. Thank you. Again, do you really want to do that if you're a couple hours outside of the hospital? No, but you may be significantly more than a couple hours outside the hospital. And we go back upward. We good? Yeah, there we go. Okay. Other possibilities that aren't used in normal emergency but are used in the wilderness are buddy splints. So if you've got an injured leg and you've got no way of splinting it, one thing you can do is tie one leg to the other leg, or, and this is done all the time, with fingers. So if you've got a broken finger, one way to splint it up nicely and quickly is just take a little bit of tape and splint those 2 fingers together with a little bit of tape, maybe in a couple of spots. And that'll provide support and reduce the probability of further injury. Now, could you also add some kind of stiff support to this? Sure. If you've got a little bit of stiff support, and by the way, those little SAM splints come in tiny little splints as well. So you could probably provide one of those in the palm and just hold that flat like that, or at least in a position of function. That feels okay? Mm-hmm. You're gonna cut that off because I don't feel like dealing with the tape.
Oh, you can just leave it.
Oh, okay. Or small trip so you can use that to open it if it bugs you. Okay, so that's shoulder injuries, that's body splinting. For other kinds of dislocations, including finger dislocations, you could attempt to provide a little bit of traction. So basically, you might have, and it looks pretty gory. I've done a few of these, including my father, where like it's just really kind of messed up. And if you secure the hand and you gently pull, don't do more than gentle pull, but if you gently pull, you can feel it kind of moving back into position if it just occurred. If somebody comes up to you and says, hey, 3 days ago, I injured my hand and it's really messed up, the window is closed for you. So get them to a doctor that can actually do the appropriate procedure. But if they just did it, if they just fell and the finger's out of location, you can provide gentle traction and try to move it back in. If it feels like it's moving back in, fine, and you can feel it kind of moving. If it doesn't feel like it's moving back in, don't mess with it. Do you want to do that if you're on a fishing trip, 20 minutes outside of town? No. But if you're several days out, you may want to consider that. Kneecaps, also a tricky kind of scenario. Kneecaps will often be pushed out of position. Yeah, my dad has that story where he was walking and his leg just bent backwards. My father had a knee replacement. Before he had a knee replacement, his knee was problematic. And at one point, he was walking down the street and his knee just went the wrong direction. So if that happens, you should deal with it. But anyways, one thing that can happen is the kneecap can kind of get twisted around to one side or another. That can be very painful. It can cause localized inflammation, and it's hard to bandage and immobilize. So you can then very gently move that knee back into something similar to its correct position.
See?
Oh, the knee? Yeah, I guess it's not so important when they see my knee. But yeah, move the kneecap back into its regular position. I was wondering what you were doing there. And again, if there's resistance, if it feels like the kneecap's not moving appropriately, then just let it be where it is. You don't need to mess with it. Okay. I think we got one more point to bring up. Yeah, pelvic fracture. Sherry knows a little bit about the pelvis, I think. I mean, I'm really the expert, but she knows, I think, a little about it.
Yeah, they don't know about gynecologist.
Yeah, among her many areas of expertise is she's a gynecologist and a surgeon, and she also is a specialist on pelvic injuries and pelvic pain. So this is kind of what she does, but I think we're going to be doing something that you don't normally do. So that's the pelvis. My understanding is the pelvis is quite complex. And it's several different bones that are fused together, and there's a possibility of injury there. So you want to be concerned for that. And what you can do is you can basically evaluate the pelvis. I will step up. Well, actually, I'll just show you on Sherry. And you want to do that very gently. And basically what you can do is just firmly provide a little bit of pressure inward. And then if they're laying down, if they're laying on their back, a little bit of pressure forward like that, just a little bit. And if screaming ensues, there may be a pelvic fracture, right? No more than that. No rocking, no shaking, no twisting. But you may be able to evaluate a little bit for whether there's a pelvic fracture or not. On the other hand, if you've got an MOI, mechanism of injury, that indicates the possibility of pelvic fracture, you don't need to be pushing down and causing pain. Treat it as a pelvic fracture. There's no penalty to treating somebody as though they have a pelvic fracture when they don't. So go ahead and treat it like a pelvic fracture and mobilize as best you can. You also want to be concerned about other things. You may have blood in the urine. That's a serious indication that you've got a problem. You may have gross bruising in the area, which could be an indication that there's blood building up, obviously, and internal bleeding. You certainly want to treat the patient, assess the patient, and treat the patient for shock as appropriate. And you may want to apply a gentle pelvic binder. And Sherry and I are going to show you how to do this. So in this case, I'm going to bring up, you need to think of a name for the side or down or whatever it is. Yeah, can you see that? Yeah. There is our injured person. And let's say that I assess her and I say, okay, how's this? Oh, that hurts like crazy. Okay, how's this? Oh, that hurts too. Okay. Real high probability of pelvic fracture. What I want to do is just bind it to hold it together a little bit. And there are devices that EMS use to do this. However, you won't have those devices when you're backpacking. Because I don't think any of you are going to go backpacking with an ambulance following you wherever you go. So you're going to have to kind of figure it out on your own. First thing I want to point out is that where this needs to be bound, where it needs to be stabilized, is not what you'd normally think of as the pelvis. In fact, I don't know how Sherry's going to answer this. Sherry, put your hands on your pelvis. Yeah, this is actually great. So notice where Sherry's hands are. Okay, to be clear, that's not where the pelvic binder goes. The pelvic binder goes here on what we call the trochanter. So basically, where your femur, where your leg bone connects with your hip, that outside portion called the greater trochanter, that is the spot that you want to put the center of your binding on. So think of it as like, I don't know what you think of. But I think it was like the low-riser jeans from the 70s or something.
That would be a little too.
That would be a little too low. Yeah, right.
Right at the bone.
Yeah. And the reason is, of course, that's where you're going to get motion, and that's where you want stability. And if you've got stability there, the stability here will come. But if you put stability here, you're not necessarily stabilizing the lower portion. So you kind of want to get as much stability as you can. Now, is this a cure for anything? Of course not. We're not providing cures. But this kind of binder could provide you with a little more stability, a little more sanity, so that you can evacuate the person from a dangerous scenario without causing further injury. Remember, that's our goal. What I've got here is a sheet. In this case, it's kind of a thick sheet. This is, I guess, a cover, actually. But it's just a sheet that we're going to slide under the patient. And we can do that by taking advantage of the natural space and bending motion of the knees. Slide underneath, go ahead and take half of it. And then once we've done that, we explain to the patient what we're doing. We're going to slip this under you, and we gently slide it back and forth. There we go. Until we get it basically aligned with what appears to be the greater trochanter of the patient. And in this case, you can identify the greater trochanter because you can feel both heads of where the patient's legs connect with their hips. That may not be true for your patient. We're then going to pull this over and just make one overhand pass with it. Go ahead and take that sign. And then pull. And that's it. We're not providing massive amounts of force, just enough force to help stabilize and hold things together so that things aren't going to start shifting significantly. Then we can take whatever clips we've got. For example, something out of your first aid kit and lock it in place. Or a clip you use for camping and lock the other side in place. Or, the piece. That's all right. That's all right. Or whatever else we've got. And ideally, we'll have 2 or 3 clips. And it could be like, I don't know, the clip on your potato chip bag. It could be a baby pin, whatever it is. and hold it in place. If you're really daring, you might be able to like flip it over and do a square knot on this, but I like it better like this because then I can adjust it. If it ends up being too tight, I can loosen it up pretty quickly. If it ends up not being tight enough, I can tighten it up pretty quickly. But this will provide some security. And now, if the person has a pelvic injury, I'm feeling a little bit better about log rolling them onto a stretcher or otherwise moving them and getting them out of an unsafe scenario and getting them to care. Is this definitive care? No, but I will tell you that if you've got a second type of injury in an ER, one of the first things they will do is get you in a pelvic binder. Before they do x-rays, before they do anything else, they want to make sure as well that they don't do any more harm as they're providing care. So this is actually a really important step if you've got somebody who you suspect an injury in the pelvis. Anything else they should know about pelvi? Is it pelvi? What's multiple?
Bonuses. No. I generally don't do this.
Right. Yeah, it turns out that the
I
surgeons don't actually go to your home and prepare you for transit ahead of time. Ridiculous. It's so lazy. And again, things are going to get weird. When you've got broken bones, body parts start looking really funky. They start looking bent in strange ways. They start looking disconcerting. Don't let that throw you. You are the care provider. You are the emergency first responder. You are the first responder because you're getting there way before the first responder gets there. You've got to provide assurance. You've got to provide professionalism. You've got to provide comfort. You've got to provide care for that person before anybody else with any kind of training is there to help. So don't let yourself get thrown. These injuries tend to be potentially gruesome, but the basics are all the same. ABC, is the person breathing well? Is the person have good perfusion? Am I concerned about shock? Is the person responsive? And then once I'm okay on all that, and particularly in this case, because broken bones themselves, in and of themselves, again, it's not seconds, it's not minutes, it's hours you have, right? So don't freak out. Immobilize the injury to make sure that we're not getting further damage, to provide pain relief, and get the person to care. Depending on how serious it is, depending on what other kinds of potential harm there is, head injury, spinal injury, et cetera, you may need to move more quickly, or you may have all the time in the world. I mean, not all the time in the world, but plenty of time. So don't let yourself get thrown. You are the professional. You can do this. All right. I'll see you in the next video.